Hi, it's Dr. Fox, licensed psychologist in the state of Texas. And in this video, we're going to talk about, is it bipolar or BPD? And this specifically goes to complex BPD, and is this a component of your complex BPD? And we're going to break down BPD in this video. We're going to look at those different components, overlapping components, separating components. We're going to get into a lot of components. So hang on tight. Here we go. Stick around. And let's get started. Please like, share, and subscribe. That would be great. And let's get started with, is it bipolar or BPD? Here we go. So we first want to help identify if it's bipolar or BPD symptoms. So what we're going to do is we're going to talk about how common is it? What is the age of the first symptom? And what are the similar symptoms, those overlapping symptoms, and making that bipolar disorder and BPD distinction. So we're going to build some insight here. All right. We're going to try to help you separate it as well. So here we go. All right. So how common is this? Well, bipolar disorder and BPD are comorbid in approximately 27.6% of cases. That means approximately 20% of bipolar 2 patients were diagnosed with BPD. Only 10% of bipolar 1 patients were diagnosed with BPD. Now, the big difference between bipolar 1 and bipolar 2 is that bipolar 2 is a hypomanic episode, which means that you have high highs, but they're not as destructive and impairing to your socioeconomic status and functioning. Some folks with bipolar 2, when they're in that hypomanic phase, they're actually still able to go to work. Yeah, they're cleaning a lot, and they may be gambling somewhat, and they may be a little more irritable, but they're able to function to a greater degree compared to those with a manic episode or in a manic phase. And that's your bipolar 1. And that manic phase is very, very destructive of an individual's socioeconomic dysfunction. That's their ability to go to school or go to work, as well as maintain social relationships. And they're having really high highs, right? And they have gambling sprees, spending sprees, promiscuity. They can go on drug binges, things like that. So that can all be in the manic phase as well. So just to give that idea, as you can see on the screen, right? 20% bipolar 2, 10% bipolar 1. Now, BPD overall with bipolar disorder. So we see that there's this separation of BPD, and then there's separation of bipolar disorder, but there is overlap. And that's where this confusion comes into play. Now, bipolar 2 and bipolar 1, right, the percentages, and you see I kind of read it backwards, so we'll flip it, right? So bipolar 1 and 2 percentages in those with BPD, right? Just like we mentioned a moment ago. Bipolar 2 disorder, 20%. Bipolar 1, 10%. Okay, so when we look at it, this helps to graphically capture that bipolar 2 is somewhat bigger and takes up more of that space because there's more overlap. Whereas that bipolar 1 is not as much. You can see there isn't as much overlap into that BPD symptomatology, into that BPD sort of overlooking topology. And what's the age of first symptoms? And this is really, really important to be aware of. Now, even though the stuff I'm going to talk about, everything isn't absolute, right? With human beings, very little is absolute. We know that. So we have to consider, just because it's occurring with one or even a preponderance of individuals, that doesn't mean it's 100%, okay? So age of first symptoms. Now, the initial manic or hypomanic episode is typically around 18 years old. And BPD symptoms are likely to occur in early adulthood, which begins at like 18. So you've got that time and age overlap in there as well. Now, in some cases, what will happen is you'll see some BPD symptoms as early as 16. We got to be really, really careful in any type of situation where you would diagnose a personality disorder in someone under 18. That's because a lot of our personality characteristics, although they're present and are prolonged and habitual behaviors, have solidified to a degree, but there's still a lot of development between 16 and 18. There's still a lot of changes. It's also a very tumultuous time for everybody. 16 to 18 is tumultuous, right? There's all this stuff going on. You're growing and developing. Your body's a little weird, and you're, and not weird in a negative way. It's weird for all of us. That's 16 to 18, and it's developing in a very different way, and you're trying to get used to it. You're trying to move into adulthood, leaving childhood and adolescence behind. So it's that awkward position and situation. So it can be very, very challenging. So we see that these symptoms start to show, which is why for individuals that are around 16, between 16 and 18, we want to make sure that those BPD symptoms, that they've been there for at least 1 year and consistent, because if it is in reaction to an identifiable stressor, it could be a maladaptive reaction to that identifiable stressor, which is not a personality disorder. It's a maladaptive response to a stressor. Okay. And once that stressor goes away, presumably, so would the maladaptive behavior, or it would at least attenuate to a pretty large degree. So that's a little bit about age of first symptoms. And what about those similar symptoms? What about the overlap, right? Here's the confusion. So the symptom overlap with the manic phase and BPD behaviors, all right? So we see that individuals with BPD and those that are in the manic phase have irritable mood, racing thoughts and ideas, right? All these things keep floating through your mind and stuff. When individuals with BPD, when they get excited, they get all these neat ideas and all these things are running through their mind and things like that. And they have rapid speech because they want to tell you all about it and they're super, super excited. Well, people in the manic phase do the same. And a lot of times they'll also engage in risk-taking behaviors too. That could be promiscuity, substance abuse. It could be reckless driving, drinking and driving, things like that. So that's risk-taking behaviors in the manic phase. Also sometimes in folks with BPD as well, because sometimes they're like, heck with it. And they don't say heck with it. They just say, the other one, I'm not going to say it. And they just say, I'm just going to do it because I want. I'm going to throw caution out there. I don't even care. And what happens is sometimes that BPD becomes so overwhelming, and that voice in their head, it's not a psychotic voice. Sometimes it's an inner critic. Sometimes it's family in the head that are talking to them and telling them, hey, just forget it. Just do it. Just do it. Just do it. And that volume becomes so loud and intense that they just do it. And then also it goes to that impulsivity. And that inner voice that we're talking about is also adding to that impulsivity. But we also see that in that manic phase, right? That's that symptom overlap. Now, let's differentiate bipolar 1 and bipolar 2. Okay, we have that manic episode. Now, this is an individual can't successfully participate in required daily activities, right? I alluded to that earlier. They may even need hospitalization in a manic episode due to delusions or hallucinations, which are at a higher probability to occur in a manic episode. Now, there's also that high probability of impaired insight into behavior and emotions, which means, right, they're engaging in behaviors without slowing down, looking at those behaviors and the destruction that they could cause on their life. Take a look at that hypomanic episode. So the hypomanic episode, we see family and friends are noticing a little difference in behavior and mood. They're kind of like, what's going on with Jerry? I don't know what Jerry, that's just an example, right? They may have impaired insight. The individual, what this means is the individual may recognize that they have this increase in energy, this increase in low frustration tolerance. They recognize there's something different about them. Okay? And they may be able to fulfill some of their daily activities. Talked about that earlier, right? It's not as destructive on your socioeconomic functioning, but it certainly can be. And then also that last component for a hypomanic episode that we're going to talk about is its impairment is present, right? But task completion is still possible. And even in some cases, again, it's likely. So really, how are you able to complete your task? Are you able to go to work? Are you able to get your kids ready for school? Are you able to, take a shower, have good hygiene, continue it, keep it up? Are you able to go to sleep? Are you able to slow down, think through components as well? That's your hypomanic aspect. Now, bipolar 1, bipolar 2, that big difference, generally they're differentiated by the severity, right, which I talked about earlier, and the length of time the symptoms are present. Typically, a hypomanic episode is going to be about 4 days and earlier. A manic episode is going to be about a week or more. Okay, could be 4 days or more. You got that gray area in there as well. So the difference in bipolar 1 and bipolar 2 is certainly timing, right, as I just mentioned. But for a manic episode, symptoms must last for 1 week or longer. Whereas that hypomanic episode, the symptoms are there and present for 4 consecutive days or more. So you notice that or more is that overlap, and that's why these are really complex disorders. And we're not even into the BPD stuff just yet. So it is confusing and it is hard to discern it, but the episodic and the time component is really, really important. So let's talk about the depressive phase, right? And the confusing overlap. So individuals with BPD, they experience these depressive spirals, and that's low energy, prolonged sadness, decreases in activity, poor concentration, difficulty with decision-making, excessive worry and anxiety, feelings of guilt, and possible suicidal ideation, intent, or gestures. And these are all components associated with a major depressive episode. So what we're looking for severity. How severe and intense and disruptive are these feelings of guilt? In a depressive spiral, it's not as severe as a major depressive episode. However, is that they're still there. There's still issues, but they're not necessarily to the extent where they're so disruptive in your life. Now, they may be, and a lot of individuals with BPD do also experience comorbid major depressive disorder. And for some folks, that's their complex BPD. But now, since we're talking about bipolar disorder, we'll kind of stay in our current vein, even though we're talking about the depressive aspect, is those depressive spirals just aren't as intense. They're there and they're disruptive and they're hard to manage, but they're not to the point where they're incapacitating, where there is a severe adverse impact on that socioeconomic dysfunction, right? Your ability to go to school, go to work, take care of your family, do your chores and follow up on your responsibility, as well as maintain relationships. So let's separate it out. We did the overlap. We're going to separate it out. So here we go. All right. So let's talk about symptom distinction. Timing and severity of symptoms is critical. Look, it's even written in red. Critical. Okay? And we want to know, is there a trigger, emotional button, or core content activation? What drove these symptoms? What are the drivers? Was it an activation of or an issue of abandonment? Is it a rejection sensitivity? I'm afraid you're going to leave me. I'm afraid I'm not going to see you again. Or is it a trigger? Is there something negative that happened, right? You texted somebody and they didn't text you back, or they texted you something that was really rude and very judgmental, and that triggered your emotions, your memories, your past, which that's what the emotional buttons are, is instances that occur that bring up all these negative memories that are really painful, and it triggers all these emotions. And then, of course, core content, and typically for those with BPD, their core content tends to be, and it's not the same for everybody, everybody has different ones. Certainly be abandonment and emptiness are kind of the two common ones that I see, but everyone has different ones as well. So you can have those two, and then you could also have some that are more specific to you and the issues that you're experiencing and the past and experiences that you've had. Now, we also want to look at, is this behavior outside of the usual for you? And what happens is those with BPD is that they tend to respond in a particular way, right? It's this prolonged series and utilization of maladaptive beliefs, behaviors, and patterns. So we see these patterns keep coming up that are certainly due to triggers, emotional buttons, right, and core content activation. Or is it episodic? Are we seeing lows? Are we seeing highs? And during the highs is when we see all of those adverse, acting out behaviors, intensity that we talked about during those manic and hypomanic phase just earlier. The depressive phase is more severe than that depressive spiral. So is it outside of the usual? That's important as well. Now, bipolar disorder, there are periods of stable mood and behavior when they're not in a manic and depressive phase. However, those with BPD, they have periods of instability that are frequently peppered, right, throughout their history, right? Throughout your history, you have these periods of instability, right, where you just kind of, you just decompensated, you're on this destructive streak, so to speak, and you're engaging in those maladaptive beliefs, behaviors, and patterns. They're very disruptive to how you're living your life and what you're doing. So it becomes very, very complex and hard to manage. And we see those moments. Okay. However, they're much more common, and we don't see that ebb and flow. What we see is a very erratic kind of actions and reactions to situations, issues, perceived issues in your life. That's BPD. with your bipolar disorder, right, you see more of those high highs and low lows. Bipolar disorder is at an increased likelihood to have long-lasting and less turbulent relationships. Now, BPD, we know that they're likely to have relationship disruptions, and that can often be due to angry, impulsive outbursts, paranoia, and idealization, and they tend to devalue their partner. And that devaluation also tends to go with that idealization, right? Is that they're heroes, and then something happens, they don't text, they don't come home on time, whatever it may be, and then they're zeros. And you don't see that with those individuals with bipolar disorder. So that's one of those big distinguishing factors as well. Now, bipolar disorder, they're more responsive to medication than those with BPD. And that's really important to be aware of, is because there's no medication for personality. And that's why I think identifying core content and surface content is so important. And you see that surface content is typically responsive to medication. Medication can really help to treat and lessen surface content. Surface content can be bipolar disorder, right? Manic phases, depression phases or episodes, as well as anxiety, PTSD issues and symptoms, things, psychosis, things like that. Whereas there's really no medication for abandonment fears, rejection sensitivity, feelings of emptiness. And so that's really where that confusion lies. Okay, so the next slide, here we go. The distinction is based upon the effectiveness of medication on bipolar, as it significantly reduces not only severity of manic and depressive episodes, but also lengthens the period of stability when taken as directed. And see the little Y there? I already gave you the little Y. Isn't that great? Because that's why we have that core content and surface content, because medication treats surface content. Right. Now, here it is reiterated right there on the screen, so you have it. So sometimes I get ahead of myself. I get a little excited with this topic. I'm very fascinated by it. It really energizes me, and I think this is so important to put out there so people have a greater sense of understanding. In which we already talked about this, right? Medication surface content, not BPD core content. So I hope that you enjoyed the video. You can learn more about this by reading my book on complex borderline personality disorder. And in the book, we talk about early warning signs, mood tracking, cognitive biases that come into play, and how to restructure your cognition. So I hope you enjoyed the video. Please like, share, and subscribe. You like that? And thank you all so much for your time and attention. Please be well. Bye-bye.